Hello everyone, it's my very great pleasure to welcome you to the annual members meeting for Mid Cheshire Hospitals NHS Foundation Trust, which, as you know, incorporates Leighton Hospital, Victoria Hospital at Northwich, Elmhurst Intermediary Care Centre, and of course CCICP, which are community focused colleagues. It's great to have the opportunity to present, albeit virtually, our overview of the 2020-21 year. It has, of course, been an extraordinary year for lots of fairly obvious reasons. But I think, as you'll be able to see from today's meeting, it's still been a year in which the Trust has been able to make tremendous progress. If we haven't had the opportunity of meeting before, I'm Dennis Dunn. It's my great privilege to be the chairman of this marvellous organisation. And I'm joined on this senior call with senior colleagues, members of the board of directors, executive directors, non-executive directors, as well, of course, as members of our governing council. But this is your NHS Trust as members. We are simply the custodians of this trust on your behalf, working on your behalf and on behalf of our patients. Next. So the programme for this afternoon's meeting is that I'll present a brief overview of the year and the changes that have taken place to both the Board of Directors and Council of Governors. We'll then hear from our lead governor, Dr. Catherine Birch, who will present a report on the work of Council during the 2021 year. We'll then hear from James Subner, our Chief Executive, who will look at the key achievements and challenges of the year that we faced, followed by the Director of Finance, Russ Favager, who will show you just how challenging it is to operate in this NHS presently. And then we have two very senior colleagues joining us for presentations, which I think we're particularly looking forward to. There are some background papers that are available on the Trust website that you might find helpful to review either during or perhaps better still after the meeting has taken place. And at the end of our presentations, there'll be an opportunity to answer any questions that you might want to ask, and you can post those questions in the chat function of this Microsoft Teams software. Next. Now, I want to start by saying that this is indeed a current picture, but when I look in the mirror, I see a younger, slimmer, darker-haired chairman of the Trust. I think it's called a doppelganger, is the vernacular, but I've yet to meet this chap. Next. I want to start the meeting, please. Thank you, Jonathan. With this comment, which really sort of rings true for me to reflect the year that we've had. And I've just seen the determination and the resilience of our staff as individuals, but as teams as well, overcoming truly unprecedented organisational, professional and personal challenges to provide the best possible care for our patients. And it's very humbling to be involved in the senior leadership of this organisation and to work with such dedicated and talented colleagues. So in welcoming, I'd like to first, if I may, acknowledge and offer as a Trust our very sincere condolences to all those who have sadly died in this year as a result of COVID, including sadly colleagues of ours in the Trust and those that have volunteered and have provided their talent and time most generously, some of them over many, many years, for the benefit of our patients. Despite the challenges, we've moved forward at pace to introduce more agile ways of working. We've had to simply find new ways of doing things to stay effective. And a lot of that has been using the sort of digital technology which we're using for good purpose in this meeting today. Now look, although 2021 was a period of great uncertainty, and of course further significant changes on the horizon in health infrastructure, our revised approach to systems working and the proposed legislative change in preparation for wider health systems working going forward has meant that as a trust in preparation, we've needed to extend our constitutional boundaries. And later on the presentation, you'll see a slide, in fact, in a few moments, where I'll briefly outline those constitutional changes that have taken place. And by way of introduction, I just want to say that the year started actually on a significant high, 2020. It was the time when we received from CQC the announcement of the third consecutive rating for the trust overall of good, an official rating as good. 3 consecutive occasions that has happened. That's almost unprecedented in the healthcare system in the UK. Richly deserved, I have to say as well, and a true reflection of the quality and the safety of care that we give to our patients. So how best to describe as an overview the year of Mid Cheshire Hospitals last year? Next. And I decided I'd simply do it in numbers. And they were really quite staggering, these numbers. And if I start very, very briefly, just to go through them from top left to bottom right, over 450,000 total patient engagements in that year. Almost 250,000 outpatients seen, 170,000 images. We now have almost 5,000 staff. I think that makes us, as a trust, the largest employer, certainly in South Cheshire. I'm not so sure I like the visual scalpel on this particular slide, but undeniably 16,000 procedures performed, 77,000 visits to our A&E and still rising. And that really is something that is focusing our concentration of minds acutely, I can assure you. Joyously, over 3,000 births in the year at Mid Cheshire Hospitals. We have over 500 beds. We've invested almost £20 million in year in maintaining, improving the infrastructure that our dedicated people work in. And this is a large organisation, £321 million operational expenditure in that last year. And we're very, very pleased and delighted to have over 9,000 members of the Foundation Trust. So we're a significant employer in the region. We make a massive contribution financially to the regional economy. But all of those, without exception, are less important to our primary motivation and objective, which is supporting our patients. And that we're trusted with their care, that we're trusted with your care at a time in people's lives when they are most vulnerable, most at risk. It's just so humbling, such a privilege that people put their trust in us as a trust to take care of them and be there for them and hopefully make them better. And if we can't do that, to be compassionate and to be dedicated to their care, whatever their needs and whatever their challenges. But with that comes a tremendous responsibility for all of us in the trust, for all 5,000 of us in the trust. And that responsibility is to be the very best that we can be. Next. Now, as chairman, I chair the board of directors and I chair the council of governors. And we've had some changes. And we've had people that we've said goodbye to in this year, including from our board, some non-executive and executive directors who've gone on to do other things or have retired, but we've also welcomed some exciting new talented people to take their place. And Dr. Manoj Agarwal is a new non-executive director, a consultant psychiatrist professionally. Oliver Bennett has joined us as Chief Operating Officer, and Dylan Williams, our Chief Information Officer, is so shiny and new, we don't even yet have a photograph for him. But those are very welcome and recent additions to our board. Next. We've also had changes to our Council of Governors, and we've said goodbye in year to 3 very dedicated colleagues who were staff governors, Rob Platt, Jenny Newman and Lynn Evans, and we welcomed new governors in Erica Morris and Madeline Abbey, who are stakeholder organisation, partnership organisation governors, and who are already making a good contribution to our governing council. Next. And we've had some governor elections as well within the year, and we're delighted to have welcomed new governors John Barsh and Pat Griffith Weston, as well as 4 new staff governors, David Smith, Daniel Pender, Julia Hudson and Kate Skinner. In terms of governors who've been re-elected, Pat Passela and Dr. Catherine Birch, our lead governor, who you're going to hear from just next. Next. And finally from me, the changes to our constitution that I mentioned earlier. This is about making us fit for the future in a very changing environment that we know that we're already starting to face, but we'll be facing increasingly as we go forward in 21-22. So we made changes to the patients and carers constituency. It was a separate entity in the provision of council membership, which actually was, if anything, quite confusing, not least because all of our public governors represent patients and carers and those 2 constituencies, as well as others. So the constitution paper outlining the changes was circulated to all of our members, and if you wish to review it again, it is available on our trust website. Now, undeniably, governors have not been able to engage with the membership in ways that we have done historically and traditionally because of COVID and the challenge or the inability to meet face to face. But we have kept governors informed through digital engagements like this one. And in fact, I think we probably enhanced communication with governors. I see our lead governor nodding, which is always a good sign. As things may be relaxed more as we go forward, let's hope so, I don't think we want to lose the effectiveness of the new ways in which we found of working to very good intent. But the formal changes to this constitution do require the approval of all the members, and particularly the members on this call. So if you're happy to accept the changes were for good reason, and they have been approved by both the board and by the full council of governors, then please either make that comment in the chat, or if conversely you have any reservations about those changes, likewise, please put a comment in the chat. So I'm grateful to you for that. Those are the principal overview facets, if you will, of the trust in the last year. And I'm very pleased now to hand over to our lead governor, Dr. Catherine Birch, who will take you through some of the work and the very valuable and essential work of our Council of Governors. Thank you, Catherine.
Thank you very much, Dennis. And I just wanted to spend a few minutes talking about the work of the Council of Governors over the last year. But for members who may not be familiar with the Council of Governors, how it works, who sits on it, etc., I thought before I started to talk in detail about what we've been doing over the last year, it might be worth just talking a little bit about the Council, what its role is, and the various activities that we get involved in throughout the year. And it's important to say from the outset that as Council of Governors, we are here to represent the interests of various constituencies, and those constituencies are very much in terms of the general public and the membership. And you'll note from the constitutional changes that we are no longer having patient representatives on governors, because all of us on Governing Council are here very much for the interests of patients and the wider public. That's why we do what we do, and that's why we're so vested in what Mid Cheshire as a trust does in terms of the way in which it delivers care, treatment and support for those of us who live in Cheshire and the surrounding areas. So you can see from the slide there, we have public governors, we have a number of staff governors, and then appointed governors from a number of our key stakeholder organisations. And that gives a really interesting blend and mix of different expertise, different perspectives. And we're a large council of governors, numbering nearly 30. And it's my role as lead governor to act as a sort of bit of a conduit between the board and the council of governors. But we work in a very flat structure. It's not hierarchical in that sense at all, and it's very much about ensuring that the views and interests of members and the wider public are able to be represented in key discussions affecting the organisation. It's important to say as well, we don't have a managerial responsibility. Our primary role is to hold non-executive members of the board to account for the performance of the board as a whole, and I'll talk a little bit more about how we do that on the next slide. So the way that we do that is that we attend key meetings. We're involved in discussions with non-executives who chair the key committees for the organisation, and that enables us to ask challenging questions, to explore particular area around what Mid Cheshire is doing, the care for patients and the outcomes that are achieved. And crucially, patient experience and outcomes is absolutely central to everything that we are focused on. We do have some other responsibilities that are set for us in terms of what governors are expected to do at national level. So we, for example, we have to approve the appointment of external auditors, and we are involved and indeed approve non-executive director appointments as well. So Dennis mentioned just a moment ago about the new non-executive director who was appointed recently, who we'll be hearing from later. And we were very much involved in that appointment process throughout. We receive updates on various issues, so everything from some of the challenges that the organisation is facing to hearing from patients about the impact that the care has had on them, to really being able to talk to staff and understand what it's like to work in the organisation. And we also contribute through strategic discussions and through listening to staff about forward plans and quality priorities as well. If I could have the next slide, please, Jonathan. Thank you. So one of the things that we haven't been able to do this past year as much as we would normally do are some of the aspects which really give us that much deeper perspective into the organisation. So things like patient safety walkarounds, where we join members of the board who regularly go out into clinical wards, clinical areas, talking to staff, talking to patients on a monthly basis, and governors are very much included in that, and it gives us a chance to see things on the day as they're happening and talk to staff. And because of obviously the restrictions around COVID, some of these activities have not been able to be undertaken in the way that we would have done. What we have done, however, and Dennis alluded to that a moment ago, is that because we have moved a lot of our activity online, which has meant that we've lost some things, but we've gained others, we have been able to really manage our relationship with the non-execs and with the trust board and other parts of the organisation really well. And one of the things that we're really keen to do is to see how we can build on our experiences and really sort of develop that further. And you can see there in the little diagram, there's lots of things. Each month we will have meetings with the non-executives. We may have also government-only meetings. Some of us sit on the Nomination and Remuneration Committee, which is about key appointments for the Trust. We have discussions with the Chair, with the Chief Executive, and crucially, members that elected governors, patient representatives lead on the Membership and Communications Committee. And that's really the main way in which we look at membership, engagement, and a whole raft of activities that are focused on our members. So that's really central to what we do. If I could have the next slide, Jonathan, please. Thank you. So in summary, sort of from accountability and challenge, which is really what we're here to do day in, day out, the governors bring a wide set of skills, expertise and experience. We have colleagues on the Council of Governors who have no previous experience of working in the health sector, but bring perhaps expertise from industry, from local government, etc. Other governors have clinical backgrounds, others have education backgrounds, others may come from a volunteering perspective, so really wide set of skills. And that really does help with the interactions and just draw you to sort of my sort of reflection at the bottom, really, in terms of the approach that the Trust has with us. Very open, very transparent, very honest, which is what's needed about some of the challenges which the Trust is experiencing, but also some of the ways in which we can help and support the Trust to develop in the way that it needs to, given some of the issues that we're experiencing at national level. So in terms of our particular accountability perspectives, as I said, focusing on patient safety, really, keeping that absolute perspective on the quality of care and outcomes. But I think something that we've really recognised in the past 18 months is, whilst as governors we have that sort of DNA almost of patient care and quality. Something which has been a real concern for us, particularly because of the pandemic, has been staff welfare and staff well-being. And I think it's probably fair to say as governors now that there is as equal a focus on our staff as there is on patients and care, because obviously from our perspective, great care is delivered by great staff, and I think it's just important to ensure that as governors we don't lose sight of the staff welfare and well-being, and that's something that our staff governors, who are elected by other staff members, are really focused on. So I think certainly for us going forwards, it will be very much about keeping patient care at the heart of what we do, but staff welfare, staff well-being, staff concerns also being something that is absolutely firmly in our focus. If I could have the next slide, please. Thank you. And just to summarise, we talk very much about our membership, and a quick breakdown of that for you in terms of what's happened over the last year is we've got just over 3,500 public members, just over 1,000 patient and care members, and obviously staff and volunteers at the Trust as well, nearly 5,000 members. That gives us a total of just over 9,500, and we're looking to increase that over the course of the year, and that's being led by one of our very established and very experienced governors on the membership committee. But I think what I would just say, and if I could have my final slide, which I think is my final slide, what I would just say in terms of membership engagement, it's absolutely crucial to us that we are able to hear from, understand and appreciate your views. So please do share your views, experiences and suggestions with the governors. There is on the website a breakdown of all of the governors, which constituencies we represent and how to contact us. There's annual members meetings such as this, but we also have special members meetings throughout the year which might profile or showcase a particular topic, and we'd really encourage members to get involved, to understand more about how care is being provided across the locality, and to really sort of look at how they might be able to contribute to that, or indeed think about becoming a governor themselves. We're always looking for new governors. We can only serve a particular term of office. I'm in my last term of office now, so we're always looking for people who are interested from our membership to really come and join the governing body, and this is a great way to get involved and find out more. Obviously the membership newsletter goes out, but there's an invitation as well to come and observe our Council of Governor meetings and Board of Directors meetings, so you get a sense really not just through this meeting but throughout the year of what's happening at Mid Cheshire and how you can get involved. Thank you. Thanks, Dennis.
Catherine, thank you very much, and thank you to all of our governors who provide tremendous support for the Trust. Much of it unseen, I have to say, but very much appreciated. There may well be questions towards the end, Catherine, from your around your, or indeed beyond this presentation, around your invitation to learn more about the work and the role of governors. It's my great pleasure to introduce next our dynamic Chief Executive, James Subner, who's going to give us an overview of how the year has been operationally. Thank you, James.
Thank you very much, Dennis. So I'll move straight on to the next slide, which is a bit of a menu of what I'm going to talk about. A few bits of information around the key challenges and achievements that we've had in 2020-21. A little bit about the performance and the quality of care during that period, and it's an unusual year, very unusual year for us to talk about. You'll see why shortly, but obviously the pandemic's had a huge impact on the way the NHS has worked. I'm going to talk to you a little bit about the trust strategy and moving forward and our plans for the year that we're currently in. So if we could start with the next slide, please. So the major challenge of last year you would expect me to talk about would be the COVID pandemic, and what that meant for us as an organisation was much like everybody else in the country, real uncertainty, not knowing what we were going to have to deal with. And it's interesting now when you think back to those early stages of really not knowing anything about this virus, what it was going to do, how it was transmitted, yet needing to get on with delivering life-saving treatment and care to people on a daily basis. We had to redesign our services on a really enormous scale to support patients with the virus. So for those that were coming in very early on, huge amounts of additional critical care capacity was required, huge amounts of additional bed capacity. We had doctors, nurses, allied health professionals, people from all sorts of disciplines retraining to support the pandemic effort, which was phenomenal to see. We had to continue to provide other things like emergency care and urgent services and cancer treatments as well to keep the normal NHS work going in as much as we can. But there's no doubt, like everyone else in the country, that the virus took over for quite a significant amount of time and made looking after everybody else safely really very challenging. We had to postpone some planned treatments and elective surgery, and I'll talk more about that in a moment. And again, that was the same nationwide. The risks of bringing people in, giving them anaesthetic and doing surgery that wasn't life-saving or life-threatening from a sort of imminent need perspective was greater than the risk of people contracting the virus, particularly post-anaesthetic. And lots of redeployment of staff, as I already said, about people trying to work in different ways, reduce social contact, start to use electronic systems, start to use video conferencing and calls. And a lot of our staff have spent the best part now of 2 years in PPE and still do that now through the hot summers and the difficult and long days. So real different NHS to the one we knew before. Next slide, please. The key achievements during that time, well, I think COVID is one element of this, and there's no doubt that the learning that we've experienced from working in a very different way has been phenomenal. Some of the pictures you can see there, the top there, that's our vaccination centre. And we put our hand up very early on in the pandemic when the very first vaccines were coming out, which had to be sort of frozen storage and could only really be put in place in major organisations like ours. And we put our hand up very early on to be one of the first vaccination organisations locally. And we vaccinated 47,000 people really, really quickly. And in particular, vaccinated those working in social care and care homes in an effort to protect our population locally, hospital staff, primary care staff, people working out there in the community, and patients with severe risk as well. So a huge effort there to do that very, very quickly. The recovery trial was a very early trial that was trying to understand how COVID was affecting patients and treatments. And we were the top recruiter in the Northwest for the recovery trial, which for an organisation of our size is phenomenal. And we were actually one of the top few in the country. Again, something that's very well led by one of our acute physicians here. From a digital perspective, you can see a picture there of the lady talking on the FaceTime Teams-like software that we put in place on our wards so that we could make sure that people could stay in contact with relatives. It was a really difficult time for patients, for staff, particularly as well for relatives who couldn't come into the hospital and in some cases still can't, to be able to keep in contact with patients who were ill and unable to keep a daily conversation going with their families. We did lots of really good innovative work around emergency planning, and how we set the organisation up to run was very different. And we used a sort of command and control process to facilitate really fast decision making, make the right decisions. And the good thing about that was those decisions were led more often than not by the clinicians working on the front line, telling us what they needed, when they needed it, and we were very quick and able to respond. Dennis has already mentioned, it feels like an age ago now, but in April, at the beginning of that year, the CQC inspected us and gave us a good rating, as Dennis said, for the third time. We were particularly pleased with that. We were also particularly pleased that Community Services, which we'd taken on board some years before, had significant improvements right across the board to good in every sort of rating category, which was phenomenal. And our community staff have been fantastic over this last couple of years, not only in achieving that, but in supporting the COVID efforts as well. Loads of progress with the health and wellbeing agenda. COVID really accelerated this. We had, as we know, quite a big plans around looking after our staff differently already. But when COVID came in, it was a different level of support that was required, and we brought everything in from complex psychological support to improvements to all the staff rest areas, supported financial well-being, and lots of other flexible working opportunities to try and keep our staff as rested and as able as they can be to continue to work in what is still a very challenging environment. And I think one of the really big key achievements outside of the COVID situation last year was we didn't sit on our hands and just deal with that. We made sure early on that we focused on making sure the long-term vision for the trust was still being worked on, despite the fact we were very, very busy with other things. And the procurement process for a new digital clinical system, which will effectively be an electronic record for our staff, which will vastly improve safety in the organisation, and also the much heard about recently hospital redevelopment plans, which I think have been a huge success in terms of both the development of that during the COVID period, but we're getting real traction now locally and nationally with our bid to have a new hospital build on the Leighton site. So the next slide just shows you the outcome of the CQC. We've still got work to do on the safe services rating. That's something that is very difficult to achieve. One of the things that really helps you to achieve that is that electronic patient record and digital system, because it improves safety by having decision support. It picks up when there's drug errors. It automatically identifies areas where things need to be done for patients that people might not know. And it's very evidence-based that a digital clinical system will improve safety. So we hope that that will take us forward on that agenda over the next few years. And you can see all of the other categories there rated good. So moving on now to the performance side of things and quality of care. Dennis has already touched on some of these numbers. What's amazing is that as Dennis went through them, they look extraordinarily high, but a lot of them were actually down significantly on the year before because of the COVID pandemic for obvious reasons. So we had a long period where A&E attendances were down, and over the whole year they were down by 20%, which was significant for us. And that's obviously because at the time people didn't want to come to the hospital, people were isolating, staying away. And our elective procedures, while 16,000 is a huge effort given the challenges we had, we would normally be doing more than 30,000 in a year. The number of babies born increased, and that was because we supported our partner organisation at East Cheshire, who, with the COVID pandemic, had real challenges maintaining that service alongside all the other issues associated with critical care. And so since the pandemic began, we've been looking after and arranging for the birth of children who would have previously been born at East Cheshire Trust to be here, and that's increased our numbers now over 3,000 a year. And we've also managed to do well still on maintaining the 18-week standard and cancer service standards, albeit not to the national standards we used to have, but comparatively pretty well compared to others in the region. So we're really focusing on how we continue to do that. Dennis has already touched on one of the big problems for us is that now we're in this sort of post-pandemic, although it's not gone away, but slightly post-pandemic situation. A&E attendances are now higher than they've ever been. And whilst we said before 70,000 was a huge amount in a year, I expect this next year that we're currently in to top 100,000 for the first time, which is an absolutely extraordinary number of attendances at hospital for an organisation of our size. No doubt influenced by people's illnesses post-pandemic, but also an increasing population. If I can move on to some of the other achievements, we managed to keep going with a number of our priority programs around our quality and safety improvement strategy. We've been having a real focus over this last year on the prevention of deterioration and sepsis in particular, medicine safety, lots of maternal and neonatal safety, and end-of-life care as well. We've had some phenomenal success with international nurse recruitment, and the Trust was struggling, like everywhere else really, to recruit nurses. And we set a challenge to try and close the gap that we had of about 200 nurse vacancies. And we've pretty much done that through the international nurse recruitment plan. We anticipated that we'd do that in 5 years, and we've done that in less than 2. So huge thanks and admiration for the team that have been involved in that, because it's made our ward safer. But if you could also imagine what this last year would have been like had we not been able to do that, with all of the extra beds we've now got open to look after COVID patients still, and also many other sick patients as well. We had some other successes, including a visit from Ruth May, the chief nurse for the NHS, who came up and was really impressed with the way our infection prevention practices were working. And on a similar line, we were award nominated and won for our Be Safe, Be Equipped campaign, which was about making sure all our staff knew how to use PPE and which PPE was necessary on a constantly evolving situation as more and more was found out about the virus. And we also launched in the year, and I'm really proud of this, Cure, which is a smoking cessation service where we actually offer all of the patients in our care now who we think might benefit from it immediate smoking cessation support. And we've managed to stop a significant number of people smoking, some of which have been doing so for decades, by offering the right intervention support and the right medicines at the right time to help them do that. And this is a really good example of how hospitals and organisations that are large, like ours, can actually influence the out-of-hospital health promotion agenda that we all want to do. Next slide, please. The Trust strategy was the other thing that, again, I think we're really proud that we managed to continue to do over this last year. The Trust was in need of a new strategy for its next 5 years. The previous one was sort of an expiration. We've done some really good work here on how our system needs to change, what it needs to look like. We've done some really good analysis of what our population need, and we've tailored a strategy for the future, for the next 5 years. Really focused on our local population needs. And what's really clear is we need to change the way we currently work from being a hospital organisation with strong community services to being a much more integrated organisation with primary care in particular, our local authority colleagues and mental health teams as well. So lots more to do on that, but we've had some really great engagement with our board, with our council of governors, senior leadership and local partners on our new strategy, and it is launching this month. So really fantastic to think about the future now, post-COVID, and all the exciting things that are coming next. So the final slide for me is the focus for the year we're in, and obviously we're halfway through this year now. So COVID recovery is a critical part of this. We've still got COVID wards open on the Trust, we've still got patients coming into the Trust every day with COVID, and we still have to maintain separate pathways for those that are COVID positive from those that aren't. And deal with all of the infection control challenges therein. So it's still a real struggle for the Trust. And I think it's helpful to make sure people understand that whilst hospitalised COVID is lower than it was, the fact that we still have to provide separate wards and separate spaces and separate rooms and separate pathways for people who might have COVID is really hampering the NHS's ability to deliver things in as efficiently as it used to. The Trust strategy development, we're now turning into sort of operationalisation over the next 6 months, which is great. So we're really starting to think differently about what the organisation will do in the future. The hospital redevelopment is hugely exciting, and our bids now to get that brand new Leighton. But alongside that, even without that, we've got a fantastic new A&E department opening in a matter of weeks, which is first class, the best I've ever seen, in fact. And a great opportunity for our organisation because we're getting so busy there. We've got new critical care units opening with an extension there, and we've done lots of work to the site, including improving car parking and other things that will continue to pay dividends in years to come. So we're obviously now moving towards this new integrated care system. There's lots of work to do. We're still working within Cheshire East and Cheshire West Place with our partners to try and consider what the future will look like there. But I remain really positive that the strategy the Trust has come up with, the strategy that our local population need, is really well aligned to that new way of working in a much more integrated way. So the future for us now for the rest of this year and into next will be how we start to change the way we work, to look at how we integrate much more closely with other agencies and continue to push for the buildings, the staffing and the associated resources that we need across our trust to deliver world-class care, which is our ambition and will always remain so. Thank you very much.
Thank you very much, James. And very good reminder that when we talk about new hospital, we're not just talking about new buildings, we're actually talking about new ways and better ways still of doing things. That's a really great overview of the year that we've been dealing with. Now, earlier I mentioned as one of the statistics for the Trust that we have revenues of about £325 million a year. We have costs of perhaps a little bit more than that. And so we have a very real challenge that fortunately we also have great leadership in. So I'm very pleased to introduce Chief Financial Officer, Russ Favager. Thank you, Russ.
Thanks very much, Chairman. Over the next few minutes, I'm going to take you through the Trust's financial performance for the year from April 2020 to March 21, known as the year 2021. Now, under normal times and years, our financial performance will be measured against a financial regime that looked at three metrics. So we would have our use of resources risk rating, and this is around the level of financial risk a trust is facing in delivering its services and whether it continues to operate as a going concern. So basically, it's saying, are we delivering value for money in an efficient, effective way using public money? And trusts are scored from a score of 1, which is being very good, to a score and no obvious concerns, to 4, which is very serious and significant risks and likely to be intervention into the organisation. So our trust in the past has been rated as a level 2, which is a good rating. We also would normally be judged against a financial control total from our regulators, NHS improvement. Foundation trusts can set their own budgets, but obviously it's in the context of an overall NHS budget and resource. And therefore, to access national monies, including capital, we'd normally have to agree what that budget was with the NHSI. And then finally, what we'd normally do, we would be judged against how we pay our invoices to help external businesses, public sector required to pay out invoices within 30 years. So this is a good indicator of the financial performance of an organisation and whether they're having any cash flow problems and hence can't pay their invoices. So I just thought it was worth giving you that context, that would be normally in a normal year, I'd be giving you those metrics and telling you how it performed. John, can you just have the next slide? However, as we all know, we haven't been in a normal year. And actually, we haven't been in a normal financial regime. And the financial regime we're used to was actually suspended in March 2020, and amended financial arrangements were put in place in response to the pandemic. So the normal system of how we operate of payment by result, which is based upon you do activity, there's a national tariff price set, and therefore you get paid in that. That was suspended, and what was happened was that the trust received a nationally determined block of income money to run your everyday activity with. On top of that, we received some additional central funding for additional costs that were arising out of COVID, and we made claims against that. And for the first half of the financial year, from April to September, the trust could apply for top-up. So if we got that central block amount, we asked for additional costs to do with COVID, and if we still were short financially, then we could apply for a top-up position. in order to maintain a break-even position. And I suppose that just aligns with the government's response to whatever's needed financially will be given to the health service. That financial regime changed in October 2020, where we moved to one of, we had that nationally determined again financial sum that we received as a block income envelope, but we couldn't then apply for top up. If that was not sufficient, then we were just asked to try and live within that envelope. We also received some nationally centrally procured personal protective equipment, or I'm sure you've all heard the term PPE, which was funded from the centre, and which, and I'll mention this in a minute, but this was needed to be accounted for within our overall financial position. And finally, it's worth saying that year on year, NHS organisations are expected to deliver efficiency programmes, and this was largely suspended in 2021. Next slide, please, John. So the headlines for 2021 was we finished the year with a deficit of £3.4 million. That included some exceptional items which were a benefit to the organisation. So we had some income donations to purchase some assets. Just to put that deficit of £3.4 million in context, as Dennis said, with income of 325 million, this deficit is a 1%. And quite simply, the second half of that year, the costs of maintaining our services, including those additional costs of COVID, were slightly higher than the block income that we received nationally. The Trust, though, was able to absorb this deficit from our cash balances that we'd built up from previous years' surpluses. It's worth me just pointing out for any people who sometimes might see a different figure quoted around our financial deficit. As I said, our position includes exceptional items. Our regulators, NHS England, judge us on a day-to-day income and expenditure, not including those exceptional items. So some of you may see a figure of £4.4 million deficit quoted. That's because that excludes those exceptional items. But that was all within the kind of control total that was set by our regulators. So they were happy with our overall financial performance. So just pulling out some more details behind that headline figure, as you see in the slide, we spent an additional £22 million on direct COVID expenditure, which was predominantly around staffing, with extra staffing brought into the Trust, including increased ITU capacity. And we also spent ourselves £6 million on protective equipment. James mentioned before that we vaccinated 47,000 people. In the year 2021, we spent 300,000 on that vaccination programme, which only started in the middle of December. And obviously, when I present next year's accounts, I'll be updating you on what we spent in the vaccination programme. And despite the restrictions of COVID on people on site, on contractors and our staff, we still managed to invest £19.8 million worth of capital. And you can see the breakdown there of £14 million in our land and building, 2.8 million in our IT infrastructure, and £3 million on equipment. I mentioned earlier about paying invoices, because this is a sign about helping our economy, and this is, really true during this pandemic. This, as businesses have struggled, it's really important that us as a public sector organisation, we pay our invoices promptly, and we paid 90% of our invoices within 30 days, and that's on the number of invoices paid, which is actually 68,000 invoices we paid in the year, which works out at about 280 invoices per working day. And if you look at the value, we paid 93% of the value of those invoices within 30 days. Next slide, please, John. So if we drill down a little more into our finances, and this chart here is just actually giving you the bare facts. There's two columns here, because one is the Mid-Cheshire position, and then the column that says group, that includes our charity account. So that's just the difference. You can see there's a small difference between the two. It's just the group includes our charity. If you come about 2/3 of the way down the page, you'll see that deficit I've just talked about as £3.341 million. We then do have some basically accounting technical changes, exceptional items that are shown on the slide. This is around the changes in the market value of our assets at the 31st of March 2021. So we get the district value to come in, he values our kind of estate, and then if that's different from what's in our books in the previous year, then there's a change there. That's charged. We have a revaluation reserve that gets charged against that, because some years it goes up, some years it goes down, so it has no impact on our income and expenditure accounts. But that's just to explain that to you. Next slide, please, John. So drilling down a bit further, looking at our income there, you can see that the vast majority, 81% of our income, has come from that block payment from the government, which is basically pays for the treating of all our emergencies, plan care, diagnostics, screening, and community services. And it's worth saying that of our total, £33 million of that is around our community services. And as you can see in that chart, £21 million of top-up funding was what was received around COVID. And if you know, those of you who can remember back a few slides ago, I think I said we spent over £22 million on COVID. So you can see how that's contributed to a part of that small deficit we have. Next slide, please, John. Just having a quick look at our expenditure, £225 million, or more or less £226 million is on pay. That's 67% of our overall expenditure. So I think a good rule of thumb for people, if they want to know what the trust spends, is that 2/3 of our spend is on pay. And then you can see that 6% is on clinical supplies. So these are dressings, bandages on the wards, and prosthesis for the likes of our hip and knee joints. We spend about 6%, £18 million on drugs, and we spend about 4% on our premises. Next slide, please, John. So looking, just drilling down a bit into our pay, as I said, 2/3 of all our spend is on pay. As the chairman quoted earlier, we employ about 4,900 people, or we did do in 2021. That's about 4,600 whole-time equivalents, taking account of part-time staff. And that was an increase of just shy of 300 additional employees from the previous year. 45% of our staff are nurses and HCAs, and that's an increase of over 230 from the previous year. We have 13% or 395 medical staff, and over 20% of all our staff, which is over 1,000 people, are estate staff, such as porters, cleaners, catering, and our admin staff. It's worth me just kind of pointing out, you can see in the chart where we've got about agency staff, we did spend £10.6 million on agency staff in 2021. And certainly going forward, as we face the financial challenges, and as a good employer, I think this will be an area of focus that we'd be wanting to convert that spend on agency into permanent full-time employees. Next slide, please, John. So just kind of looking at those areas where we spend, for every man, woman and child in the local catchment area, our hospital and our community services, we spend £954, and just over half of that is on inpatients and diagnosed and day cases. So that's people who actually stay in our hospital. Next slide, please, John. As I mentioned earlier, it's important that the Trust continues to invest in its buildings and equipment, and so that we have the latest modern facilities and latest equipment. And last year, despite the pandemic, we spent over £20 million. And as I said, £14 million was on the buildings. And you see some pictures there of some of the areas that we spent. And we're continuing to spend in the current year, where we're going to spend another £40 million. Next slide, please, John. I'm pleased to say that our external auditors, KPMG, has given the Trust a clean bill of health for its annual report and annual accounts, and an unqualified opinion. And they presented to the Council of Governors in July 2021 their year-end report. And as the slide said, that there was no material mistakes in our accounts. So looking forward to the current year and beyond. Next slide, please, John. We continue in the current year to operate under an adapted financial regime, and this is again continuation of being given a block amount of money that we are asked to live within, both as an organisation and as a Cheshire Merseyside system. I'm pleased to say that from April to September, so the end of September, the Trust was in a break-even position. As part of that block income, we continue to receive some additional support around COVID. There is also some national funding as we move forward. It's going to be available to increase activity levels, to reduce waiting lists, and we need to achieve certain criteria to achieve that. But you will have heard in the press about nationally there's £1 billion available for that. We've only quite recently we've been notified what you might hear the term H2 basically means half two from October to March. They've announced the financial regime and the funding associated with that. It will be a continuation, as I say, of that central funding block amounts given to the Trust around an envelope and asked to live within that. We're working through the detail around that, but we know it's going to be challenging, just as it was in H1. As I just alluded to before, we continue to spend on capital equipment, £40 million that we're likely to spend in the current year. Significant amount of money on our infrastructure. Operational pressures continue. Around, James alluded to these, around urgent care and workforce vacancies. So from a financial point of view, that is always a financial challenge to us. And we know that the future is going to be very challenging as we move into a sense of austerity as a country. And therefore, kind of the money that comes into the health service, we know it's going to be challenged. And we know that we're going to have to get sustainable clinical and transformational change within the Trust and across the wider system. Again, as James alluded to, changes in that system. So I just put that final bullet point, I suppose, for myself as the Director of Finance, that we really are going to require strong clinical and service leadership going forward with capable business systems and good quality intelligence to manage our finances and to make sure that we reduce any unwarranted and unexplained variation.
Russ, thank you very much. Very comprehensive overview, Russ, and I hope that's given members a real good insight into the scale and the, as it were, the depth of activity and decision making around finance that you and colleagues and we all have to take on a regular basis. I think that the final bullet point on your slide is particularly apposite in that it reminds us that all of the endeavour you just described is driven by our perception of the needs of patients and them having successful outcomes from their treatment here at the Trust. So thank you very much, Russ, for that. Now, again, there may be questions around finance later that we'll pick up in the chat line. Next, if you would, Jonathan. Well, I'm delighted, absolutely delighted to be able to introduce senior clinical colleague, consultant ophthalmologist, Mr. Manoj Kulshrestha, who's got an intriguing title, Manoj, with the title Blink, perfectly appropriate, of course, given your specialism. But it's great to have an opportunity in a members meeting to have an insight into something that I sort of describe as where the magic happens in the trust. These are the things on which we're concerned and which we're about in our everyday thinking. So a very warm welcome, Manoj, and over to you.
Thank you, Dennis, for that introduction. So the title is Blink, and as Dennis has mentioned, entirely appropriate to my specialty. And what this is actually building local integrated networks. And that's what we've been doing throughout this pandemic from the start. Obviously, we were faced with a very difficult situation at the beginning, but by using innovation and creativity, our department has actually forged links and connections with other departments within the hospital and also external organisations to allow us to see through the pandemic and restoration and beyond. So I hope that this story will be inspiring for people to maybe carry out in other departments as well. Next slide, please. So right at the start of the pandemic, within the first week, Emma McGuigan, Director of Operations, and Sally Mann came down to our department to attend one of our governance meetings. And it was really, really useful, their input, because we had actually planned a de bono hat session within that first week of the pandemic. We knew that it was an emergency situation. We knew that we had to plan forwards. So what we did is that we split our department, which consists of clinicians, optometrists, orthoptists, technicians, and optometrists, all into 4 separate groups. And we gave each group to brainstorm how we were going to plan out over the following 9 months our outpatient services, our emergency services, how we were going to plan redeployment to the wards, and also our intravitreal services. We also discussed at the time what PPE and social distancing requirements that would be needed in order to protect our staff. And we were hoping for at least 70% of the staff to continue working within the department, despite all of these problems happening. The outcome of some of that was really great, and it gave us a lot of innovation and creativity to actually take our services forwards. Next slide, please. I was part of a management team with Aqua, which is an organisation that provides education for leadership within the Northwest region. And Claire Hamill was actually leading that Aqua management group. So this was actually part of a course. And I went to that on 4 separate days in which they taught me how to plan emergency situations and how to take these problems forwards using things like the de bono hat technique, process mapping, data collection, and using brainstorming and also finding out from other members of the team how we were going to plan out those services. So I found that from a regional point of view really helpful for us to organise our department and take that forwards. We forged links with the University of Manchester. At the time, we were aware that there were universities within Wales who were providing PPE for their staff at Welsh hospitals. We found that the University of Manchester was doing something also very similar. And in the Rolls-Royce building there, they were making PPE from 3D printers. And we linked up with the Bentley factory, who took some of those plans for the original PPE, and they provided us with PPE at the start of the pandemic to actually protect our staff. And as you can see on the left-hand side, the actual shield that they supplied our staff with to keep us protected at the start of the pandemic. We were aware that we were at higher risk because since we're examining people's eyes, we get close to people and we can therefore more likely to breathe in germs, viruses. So we felt it was very important to keep our staff well protected. We also ordered plastic slit lamp shields for our slit lamps and our digital imaging equipment to make sure that our staff were well protected at the start of the pandemic. The recovery trial, of which, as we've just heard from James, we had the highest recruitment within the Northwest. Professor Martin Landray, who actually coordinates the trial on a national basis, was in my class at medical school in the same tutorial group. So it was interesting how the national pandemic situation got some of us, even from medical school, back into contact. And I liaised with Emma McGuigan to make sure that that trial was implemented in this hospital in order that the COVID patients could get the up-to-date latest possibilities for treatment and therefore recovery. So we were very, very fortunate that we had a very good medical team that liaised with pharmacy to allow that to happen. And a number of ophthalmologists who were redeployed to the wards did take part in the consent process for recruiting patients into that trial. We forged links with all of our local optometrists. We ensured that we gave them additional online training to deal with eye emergencies so that they could help us to see eye emergencies in the community outside the hospital, thereby minimising the number of patients possibly coming to the accident and emergency department. We also worked with Medisight, which is an electronic records company, in order to upgrade our electronic record system to a modern Medisight. So we are using an electronic record, and we had weekly meetings for about a year with various members of the admin, clinical and IT teams in order to implement the Medisight. All this happened during the COVID pandemic, and we supplied a lot of training for our staff within our governance sessions, and we have successfully now implemented the Medisight electronic record, and a large number of our patients are being seen using this electronic records facility. Next slide, please. Just to illustrate how we dealt with our emergencies within our department, I actually doodled on a piece of paper, as you can see on the left, a little process map of where all the emergencies were coming from: the GP, the A&E department, inpatients, the wards, optometrists, nurse practitioners, and to where those patients would ultimately feed into. And at the start of the pandemic, I worked with the emergency department's clinical lead, David Matthews, to formulate a pathway by which patients from A&E could be streamed directly to the eye department, reducing the need for them to stay in the A&E department. That would help to reduce transmission of the virus within ED, and would also help reduce the number of patients overall waiting in the ED department. So we implemented that very successfully. A number of our optometrists, registrars, consultants were carrying out ED stream sessions and casualty sessions at the start of the pandemic to make sure that we reduced that load into A&E. We also worked with our optometry colleagues who set up the Q service, which was the COVID urgent eye care service. And by that, because we had upskilled them by a lot of educational online training videos, they felt more confident to involve themselves in that to provide community care for emergency eye patients, thereby reducing the need for a certain proportion of those to get into the hospital. In the Manchester area, about 45% of eye emergencies have been seen successfully in the community, and those are increasing slowly in this area as well, now that we have established those links with the Q service. We've had discussions with the telephone 111 service, and this is a telephone triage system for eye emergencies. And we have decided that with these discussions that a certain proportion of those patients can actually be referred directly into the Q service, thereby reducing the need for those patients to necessarily come into the hospital. We're also currently in discussion with the NHS and our optometry colleagues to set up virtual community services, whereby optometrists can actually see patients in the community, take photographs with a digital slit lamp, or take OCT scans of the retina and send these through a telemedicine system directly to our computers for us to review, to determine if those patients really need to be seen or not. And that could help to reduce unnecessarily new patients being seen with macular problems, and also possibly keep patients who don't need to be seen in secondary care in primary care. So these systems and these pathways are currently under discussion at the moment. We've developed a new triage system, which we've codenamed Red Flags. And Red Flags, the acronym, we take each letter. The R is red eye, the E is eye pain, the D is disturbance of vision, the F is flashes and floaters, the L is light sensitivity, the A is acute trauma, which can be physical or chemical. The G is giant cell arteritis, which is a potential sight-threatening condition. And the S is swollen eyelids. And we formulated that into a form that is now part of our triage system. And we're working with the University of Manchester to convert that into an app to further streamline our triage system. Next slide, please. Cataract services have continued despite the pandemic. So the pictures that we see on this slide was from one of my patients who's an artist, who actually drew her perception of cataract surgery. As we can see, she saw colours of light, blues, reds, purples, greens. So the top one was when the left eye was done, the experience of cataract surgery, and the bottom one was the experience with the right eye. So we have been liaising with private providers such as Spire, and we've been actually operating on NHS patients in the private hospitals despite the pandemic. We've improved, and we've also sent patients to Optigra during that period, but we are now improving our performance in the treatment centre by overbooking some of our lists, because some patients have been cancelled due to COVID swabs turning positive, to ensure that we have maximum performance. And over the last few months, our performance has jumped in Leighton from 66% up to over 99% for some of our lists, which is great. We've been looking at streamlining our preoperative assessment processes using biometries and our POAC team to ensure that maximum number of patients are undergoing pre-op to ensure that these are ready for theatre. And we've also used innovations such as mid-research implant in theatre, which we've implemented to dilate patients' pupils, which cuts the need down for nurses to actually keep instilling eye drops into patients' eyes. And that has increased the time that a nurse will spend for each patient by over 45%, improving care and improving the throughput through our treatment centre. Next slide, please. Just going through briefly some of our services, we have a number of services within ophthalmology. The first is the Medical Retina Service, which I run together with my colleagues, Mr. Venkat Kotamati and Mrs. Deepti Senavaratne. And we provide intravitreal services where we give injections into patients' eyes in a timely fashion for wet age-related macular disease, diabetic maculopathy, and retinal vein occlusions. During the pandemic, we have improved our efficiency. We decided not to stop any of our services because we felt that since patients need to be treated in a timely manner, we needed to make sure that we continued these services in the long term. And this is just a picture of one of the innovations that we use. This is a spy device that cuts down the time of an intravitreal injection by 2/3 and improves flow through our clinic. And the patient hardly even knows that they've had an injection. In fact, by the time we've done it, they usually ask me, has it been done yet, doctor? So we've implemented that and we trained all our doctors to use it so that we improve our throughput of our intravitreal patients. And we have not stopped this service throughout the entire pandemic. Our Oculoplastic Services is run by Pedro Mule and Conal Saha. And we, during the pandemic, appointed a third oculoplastic consultant who has been a great boon to our department. And we are currently looking at working with ENT to use a minor ops room within our clinic setting to make sure to provide a service for minor operations to prevent the need for them to be listed into the treatment centre, which would give us more space in the treatment centre to do cataracts. Our Pediatric Services is currently run by Mr. Simon Walker. We're looking to appoint a second paediatric ophthalmologist towards the end of this month. Our Corneal Service is run by Mr. Victor Hugh, and he has been doing virtual corneal clinics throughout the pandemic, and he has about a 94% patient satisfaction rate with those. He's also established a dry eye clinic in conjunction with our nursing staff and our optometrists within our clinic that has enhanced the service for dry eye patients. The Glaucoma Service is run by Mr. Dan Newen, and we have had funding recently to set up a community glaucoma service with our local optometrists. Next slide, please. The graph on the left shows the number of injections that we've been doing per year over the last few years, and this is the last count was September 2021. So if we look at the last 3 or 4 years, overall there's been no change in the number of intravitreal injections done despite the COVID pandemic. And just to illustrate the importance of this for patients, on the right hand side is a local artist who has drawn a painting of 10B at the top, which she saw when she had wet age-related macular degeneration. The fluid in the back of her eye, the macula, caused her to paint with a quirky style using curved lines. So we can see that the houses look rather curved. But since we've been continuing this service throughout the pandemic and treating her with intravitreal injections, we've actually treated that fluid, and we can see the painting at the bottom is actually a painting of one of my old community clinics of Aberaeron, where she went to on holiday. And we can see that after treatment, all of those lines are straight. So that just illustrates the importance of the intravitreal service to maintain timely injections to ensure that these patients maintain their vision, to maintain their independence. For artists, that involves painting. People who drive, they can possibly drive if their vision is of driving level, and people can at least see things when they're out shopping as well. Next slide, please. And just to illustrate the point about our intravitreal services, we've got a graph here which shows the red lines at the top show the results of published studies of visual outcomes where patients have needed monthly injections over a period of 2 years. The dotted line in between them is where our service is, and our service for visual outcomes for intravitreal services well within the national studies which have been published. So that shows that by making sure that our intravitreal service was protected and continued throughout the pandemic, we have fantastic visual outcomes despite the emergency situation for our patients. And we are now looking to work with the Trust to expand those services to obtain more imaging equipment, including fluorescein angiography, OCT angiography, an Optos machine, which will enhance our service, prevent unnecessary referrals from crew to Liverpool, and also provide virtual screening and imaging in clinics for diabetic retinopathy patients. So that's all I have to say of how we've improved, and we hope to continue to improve and build on with all of the executive team's support. Thank you very much.
Well, Manoj, that was truly fascinating. I think I introduced it by saying ophthalmology was one of those parts of our service where the magic happens, and that certainly looked pretty magical, I have to confess. And over the years, I've seen my fair share of before and afters, but the before and after of the artist's work, those artist impressions, really quite dramatic.
Yes.
Thank you very much for the presentation. Thank you and your colleagues for the work that you're doing. I mean, the rate at which you've been able to maintain the service actually is just astonishing, and has been rightly applauded, not just in the Trust, but regionally as well. And I think what I found particularly is the adaptations, indeed the innovations that you've made with colleagues to not just maintain the service, but actually improve it and improve patient outcomes during this, as we've heard before, the most challenging of times. So Manoj, thank you very, very much. That was a fascinating and really helpful addition to our annual members meeting. We're obliged to you.
Thank you. Thank you, sir.
And it's a great pleasure now to introduce the second of our colleagues who are going to give us an insight into their magic. Karen Egan, who is infection control nurse consultant, and as James has said in his overview, again, an area of our work that was indeed praised very, very highly, Karen, by no one less than the chief nurse of NHS England. So welcome, and over to you.
Okay. Thanks very much, Dennis. So I have been asked to just stick to a very quick 10 minutes to talk about infection control during COVID. Now, it's my pet subject. I could still be here this time tomorrow, but I'll do my best. So I have got quite a few quite busy slides, but I'm going to pick out the key points and sort of raise the key issues. And it's funny, I'd completely forgotten. We had 3 visits from NHSEI last year, one of which was from Ruth May, the Chief Nursing Officer, and I haven't included them in the presentation because so many other things have happened as well. But yeah, thank you for reminding me.
Karen, do forgive me interrupting, but by all means take 15 if you need 15.
Okay, let's see how we go. I'm quite used to rattling through. So, okay. COVID, SARS-CoV-2, coronavirus, COVID-19, whatever you want to call it. It is a coronavirus. We know that we have 7 different types of coronavirus, and until recently we'd experienced SARS-CoV-2. If you remember the SARS outbreak in Hong Kong and China in 2003, we had MERS, which is the Middle East Respiratory Syndrome, in 2012. Now, both of those outbreaks were quite distinct. They were a coronavirus that had found its way into the human chain via animals, mixing with the genes, jumping into the human race. The viruses did cause some infection. If you remember, SARS spread across to Canada and all over the world quite quickly. We didn't quite have a pandemic, but we had a global epidemic, which meant it spread to all parts of the world. But the difference with these two coronaviruses, they didn't spread that well. So they fizzled out. We had 774 deaths with SARS. MERS was more deadly, if you like. It killed more people, but viruses basically want to mutate and get into as many hosts as possible and multiply. So they don't really want to kill their hosts off. So a virus will inevitably become milder, hopefully, potentially, whereas these two had quite a high attack rate, killed quite a lot of people off, weren't very good at being transmissible, and they fizzled out. Then when we saw another coronavirus, obviously January, February last year, I think we realised quite quickly, due to the rapid spread into Europe and then over to here and then gradually all parts of the world, I think we realised quite quickly that this one was different and this one was more transmissible. So as you know, we declared the pandemic in March. 10 days later, we had the lockdown, and the rest, they say, it's not really history, is it? Because we're still living it. Next slide, please. So this is just a graph to show the difference in the first and the second wave. So I'm classing the second wave as the winter period, when we had the predominant lockdown. The first wave is obviously from the lockdown onwards in April. These are our admissions to the trust. It's probably slightly flawed if we think about the first wave because of the testing. We weren't testing all patients. We didn't have that availability, so it could have been higher. But we do know in January we peaked at 236 positive patients in the trust. And over January and December, we had a significant amount of outbreaks. We had high community rates and high hospital rates. And then, as you see, in October, we started to see another wave with rates increasing, but they're sort of going up and down at the moment. So which way they're going is not entirely clear. Thank you. So the first wave, it was difficult. We didn't have universal screening. We had a case definition whereby we could apply screening, and pneumonia, an adult respiratory distress syndrome, and a flu-like illness, but we weren't screening all our patients. So there was highly likely to be lots of transmission in the community, limited testing in hospital. And if we're not testing, if we're not looking at how a patient presents and tying it up with a laboratory confirmation, we're not really learning about the virus in that early stage, and we're not necessarily able to apply the right treatment. So the first wave was incredibly difficult. We underreported because we just didn't have the availability of tests. We had maybe 6 at the beginning, maybe 20 tests per day, which is nothing when you've got this new virus rapidly sort of multiplying in the community population. It wasn't until April that we were testing all inpatient admissions. And again, as I said, it was not the same as SARS-1, it was not the same as MERS, it was behaving slightly differently, it was more transmissible, people had slightly different symptoms. There was a limited evidence base for SARS, and a lot of the very early evidence came from China, and it was all it was not peer reviewed, it was kind of preprint, and we were just taking what we could get in terms of that evidence base. And it was conflicted as well. The scientists can take sometimes years, and microbiologists are no exception, to agree on a principle or a route of transmission or even a treatment. So there was an awful lot of debates around SARS in the early days, and a lot of conflicting guidance coming out. Again, that conflicting guidance was very changeable. It's a political context, social context. It's not just another healthcare associated infection. Whatever we do in hospital to control it is a community context as well. So it was really quite hard in that first wave to know where we were going and what we were doing. How did we manage it in the hospital? Silver Command. We had regular infection control advisory groups that fed into Silver Command. We did not endorse arbitrary decisions. Anything of an infection control nature would be dealt with the infection control group if it needed that further ratification through Silver, and then up to Gold Command. That's how we managed it. Otherwise the governance would be quite awry, and we'd have all sorts of strange things occurring that weren't necessarily evidence-based or appropriate within the organisation. So we got through the first wave, which seems like a very, very long time ago and very different to the second wave. We got through the first wave and we completed the PIRs for some of the patient, well, all the patient deaths. And unsurprisingly, it was really difficult to do a proper PIR because we weren't testing all the patients. So we couldn't say this was a hospital acquired case or a community acquired case because we just didn't have that facility for testing. And we didn't necessarily understand the virus. We now know that some elderly patients might have symptoms of diarrhea, or children might have slightly different symptoms. We didn't know that then. So it wasn't even a test case. The first wave was something really quite unique. Next slide. Okay, second wave. So this is where we started to learn an awful lot more about COVID. And there's a lot of data on this slide. I was told to avoid numbers, but this will be mainly the only number slide I'm sharing. It shows you here, we started off in October this time last year, and we gradually increased it with our patients up to 179, and then December 319. What was going on at the time? We were trying that national 3-tier system, which didn't really work. We had a lockdown in November, and then we had a 4th tier as we discovered the Alpha variant in Southeast, and then we got into Christmas. So we saw some really, really high numbers in December, January, and that was translated into the trust with our staff as well. As you can see, we went from 40 up to 163 positive members of staff. So as an organisation, we'd already got some PPE, so that's personal protective equipment programs and campaigns in place, so we reviewed those. We increased the screening programme. We looked at trying to screen patients more frequently. So the issue with the virus is you have quite a long incubation period, potentially up to 14 days. You might not capture a positive patient in the first few swabs. We have to rely on swabbing technique, and not everyone's going to be excreting the same amount of virus. Their immune system's going to sort of balance and juggle with the viral load. So it's all very hit and miss, but we thought if we increased the screening, there was more chance of getting a positive and potentially reducing transmission through isolation. In December, we introduced a very robust and quite a broad nosocomial reduction strategy, and the nosocomial definition is any case that's sort of 8 to 14 days is classed as a definite hospital-acquired infection, and anything over 15, probable, and anything over 15 days is a definite case. So we were having quite high rates of nosocomial, which means hospital-associated infection. And we had some driver diagrams and lots of action cards that reported into Silver to try and tackle some of the escalating rates of infection. And it was round about this time that we had that visit from Ruth May, and she did appreciate some of our work streams and some of our initiatives, and that they were used in some national documents and some national tools that she shared more widely. A huge part of this was the infection control champions, so supporting wards who were very busy with winter pressures in terms of cleaning, face masks, and you can see at that peak was 240 positive patients in at one time, but over January we treated 513 positive patients. And then, hey presto, the vaccine programme starts and we can start to see a real difference. We combine that with lockdown, and we go from 513 cases to 12 in April, which is just a phenomenal reduction. And then in May, we have 10 and we have 0 positive staff. And then, of course, the lockdown stops and the government has the roadmap, and we start to see the increase again. And when the lockdown is lifted in July, we're back up to 118, 153 and 163. And then the latest figure for October was 197 positive patients. So we're kind of seeing that uptick again in terms of the wave. So some of the bits and pieces on the slide indicate what we're doing nationally. The last bit here is the revised IPC guidance. Now, we've had lots of infection control guidance over the last 18 months, and the latest guidance is supposed to tackle respiratory infections per se and not just COVID. We have been given an indication it's going to be quite different to the last infection control guidance, but we've been warned of increased rates of flu and RSV because we've been very COVID centric. And we need to remember other respiratory infections are likely to pop up because we've been isolating and locked down, wearing masks. So it's anticipated that that guidance will be very broad in terms of respiratory infection and not just COVID, but we're waiting for it any day now. Next slide, please. So in terms of reflections, the sort of qualitative element of COVID, the first wave was very new. We didn't really know what to do. We didn't really know what to expect. We just got on with it, I think. We had that brief pause to think about reset, and we had lots of restoration plans in the summer, lots of guidance and lots of things to work through to get our elective pathways back up and running. But then very quickly we're hit again with the second wave, and volume largely dictated management, because no surprise, viruses occur in winter months, and that's when we see winter pressures and other illnesses manifest. The other challenge, I think, it's not just a healthcare associated organism. If we were constantly dealing with outbreaks of MRSA or C. diff, you deal with it at work, you finish when you go home. But a lot of staff, it's COVID at home, it's COVID at work, and that's really quite tiring. It just doesn't go away. So there's all those kind of societal complexities associated with how you're feeling in work and how you're feeling at home. And then the other key bit is we're all part of the story. Again, it's not just patients, it's not just a distinct healthcare associated infection or outbreak. We're all affected by COVID in a different way. Feelings, not just our physicality. We've had a lot of guidance, prescribed checklists. We're telling people what to do all the time. We have rules, restrictions, monitoring, and we ideally need to get towards agency and empowerment. And the government talks about encouraging people to do the right things and to act responsibly. And really that's where we need to get to longer term. Resilience is a key word there, both personally and professionally. And at the side, some of the comments that I've heard from staff over the last few months, I've forgotten what we did before COVID, and that's not just about infections. Some staff have said, well, I've forgotten how to treat a particular condition because we've come very focused on COVID and managing those situations. I'm too frightened to do things without gloves now. So again, going back to that unknown quantity of COVID at the beginning, a lot of infection control measures that were put in place have had unintended consequences. So wearing gloves all the time without cleaning hands and keeping the same apron and gloves on, which is what we were instructed to do at the beginning, means that we potentially move other organisms around the ward or the hospital because we're not changing our PPE. I wear gloves so I don't have to wash my hands. I don't think that's a new thing. Sometimes you see it in food outlets, the magic gloves are always on, but we don't see any gel, we don't see any hand washing. Different guidance has confused me. Yeah, I think that's I can certainly say that as well. We need to go back to what we knew before, prior knowledge and some of our rationale around healthcare practice. We need to take on board what we've learned about the pandemic, and we need to be very aware that the pandemic and what we hear about every day is always statistics, it's numbers. But behind each number, there's a person, a story, and a journey. We can't define the pandemic purely by the rates of deaths or the rates of positive cases. And the biggest thing for me at the beginning, at the bottom of the slide here, is what we've learned about the routes of transmission. At the beginning, it was very much contact. Wash your hands, wear gloves, don't touch your face, clean everything, clean your food when you get back, get your supplies from the stores. And then we move towards the 2 metre distance in terms of droplet transmission. And it's only been within the last 6 months to 12 months that the science has really started to talk about airborne transmission. So droplets would be big droplets, coughs and sneezes that would drop. Airborne would be smaller particles that we would produce just through talking or shouting or singing or laughing. And there's been an awful lot of learning and more recent acceptance that it's not primarily spread through the contact route, it's primarily spread through the airborne route. So talking, laughing, singing, just breathing in a small room that's not ventilated, we are going to be disseminating small aerosols that will float around and hang around and not drop to the ground like larger droplets. So that's kind of changed some of the evidence base and some of the thinking. We've introduced more mechanisms for ventilation. And if you think about it, the plexiglass screens that everybody was using last summer, great for droplets, so no one's going to sneeze on you, but airborne particles will be that small, they'll just float over it. So we're changing some of the infection control measures as we learn more about the virus. Next slide, please. So what are the most effective measures? It's quite difficult to see on this slide, but it does highlight the droplets. So the droplets are blue in the first picture. Droplets will drop. Smaller aerosols will float around and hang around. They won't fall to the floor. If we translate that to the middle picture, we've got two people without a mask, and you've got different sized aerosols there. So the big green aerosols are the largest. The red ones will sort of float, and the smaller those aerosols are, the further they're going to get into the lungs and into the sort of bronchial tree. So by learning more about the airborne transmission, we can see breathing small aerosols into the lungs. We're going to breathe them in. That's where it's going to be a problem. Secretions and contact transmission is very, very minimal evidence. It's useful to wash hands. It's useful to clean for other organisms. But for COVID, it's all about what's airborne. Droplet coughs and sneezes, yes, but just breathing, coughing, laughing, singing without any ventilation is just going to cause that significant risk. When you apply a mask, you can see the difference there. You've got a very small aerosol that's managed to get into the lung. The more layers to the mask and the more they filter out, the better. But we are, we have quite good efficacy with a surgical face mask. It's about wearing it properly and wearing it consistently. So under the nose or under the chin is not useful. Having a good mask that fits well is much better than having a very sort of high-tech mask that's baggy around the sides. The last bit there is about ventilation. So again, if you think about cigarette smoke or even an odour, we open the windows and we ventilate the room. So if we have somebody that's breathing, that's coughing, that's shedding aerosols or droplets, by increasing the ventilation, we get dispersal and we kind of refresh that air. And then final couple of measures. One of those is my favourite person in the picture. If you can see there, it's Jonathan Van Tam. Vaccinations and booster programs are key, and LFT testing, so asymptomatic testing, it remains key as well in terms of picking up either asymptomatic or early symptomatic COVID. Final slide, please. Okay, so the challenges are maintaining COVID control measures, balancing the pandemic against what we need to reset, and it's really difficult. Just when we think we can move and we have some revised guidance saying we can drop some measures, we start to see increased rates again. We need to continue looking at the COVID data and the evidence, which is ever evolving, community rates, nosocomial rates. The variants here I've highlighted, and this is just to show that when we started with the wild variant, which was the original variant from wave 1, and we moved to the alpha variant around about December time, the Kent variant, we were told alpha is the 43 to 90% more transmissible, it's more deadly, and it accounts for more deaths. That's alpha, and now we're on delta, which again is more transmissible. And very recently, there's been reporting of a delta subvariant, which is accounting for 6% of new cases in the UK, and that supposedly is 10 to 15% more transmissible. So in short, the more the virus multiplies, mutates, replicates in people, spreads around the world, the more mutations we're going to get with that virus and the more changes we're going to get. So by stopping transmission and stopping the virus mutating and copying itself in people, we should hopefully reduce the amount of variants we get. But the variants, I think, is the biggest issue for us. More variants means more boosters, considering more routes of transmission and just an endless pandemic. Other organisms, we focus very much on COVID. We talk about infection control or infection control during COVID. We haven't just had COVID, we still have other patients with other organisms. We haven't had norovirus, largely because of cleaning masks and hands. We've started to see some RSV and paediatrics, but we haven't had the overload that's been suggested. We still had MRSA, resistant organisms. We still have C. diff. We've had an alarming number of TB cases in the community, potentially due to patients healthcare in the same way, which will lead to an unpredictable epidemiology. So we've changed the way we do healthcare. We've changed where people have samples taken. They're not visiting their GPs in the same way. So we're dealing with other organisms, but we're dealing with different patterns of organisms. COVID has thrown a lot around infection control up into the air. So it's not just COVID, it's how do we re-educate and re-support our staff to deal with other organisms, and what does that hospital acquired infection picture look like when we come out of COVID? I don't know, but we're still in it, and we're still seeing some of the effects in terms of how COVID has affected what we do. In the middle of there, the challenge seesaw, staff wellbeing is huge, isn't it? So we have this agenda whereby we want to remind them of COVID precautions. They're tired. We want to remind them of other infections. They're tired. The resilience is low. So it's a question of education and support. I think that's all we can do, making it easy for them to get that support, help, advice, and education. I think that's the final slide. Thanks, Jonathan.
Karen, thank you very much. It's interesting looking back, actually, as you did earlier in the presentation, over the past, 18 months, and just reflecting on how that tracked out and through that period. And I think the two things that strike me from your presentation is that given how embedded COVID has become as a pandemic, the very strong probability is there will continue to be mutations for some significant period, and we have to find a way of coping with that. You're quite right. As a trust for our patients, but as you rightly say, for our staff as well, who are remarkably resilient, but there are limits to what people can cope with in that resilience. The other thing, and I think the thing that I'd draw people back to from your presentation, is just the very salient reminder that behind every statistic is a person. Absolutely. So this evening when we switch on the BBC for the 6 o'clock news and we hear how many of this and how many of that and how many of the other, just to remind ourselves, there's a patient and there's a family and there's a workplace, all affected in each one of those pieces of data. But thank you again, Karen, for not just your presentation today, but for the work that you're doing, and very well done to you and your colleagues for the support that you're giving the Trust.
Thank you.
Colleagues, that takes us on the agenda onto the part, thank you, Jonathan, for the next slide, on to questions. I've noted that there are 2 questions, James, that you may have picked up in the chat, possibly 3.
Yeah.
Do you want to have a first go at these?
Yeah, absolutely. So, John, it may be best to take the slides down now at this point so people can see us, and we'll work our way through the questions. Okay, so firstly, the first one I've got here, it's an anonymous question, but it says, concerned about the health and care bill, which will move Cheshire and Merseyside into an ICS, which is an integrated care system. Our MP has said Cheshire and Merseyside ICS will not serve the best interests of our residents. It tears our NHS apart, it's bad for patients and staff, and it will increase the role of private companies. So obviously that's a statement, but I suppose it'd be helpful to perhaps give my view on that. which is slightly different, really. I think my view is that the integrated care system approach will bring the NHS closer together, and I think it's already doing that. We're already within our local places now working with colleagues in a way that we never have before. That's been driven by the need to develop a strategy for our places and how we're going to work more closely with our local population. I think as well, the fact that it's probably going to signal the end for competition between NHS organisations, which I think is a great thing, and it's going to focus more on collaboration, and particularly this sort of potential to get rid of this commissioner-provider split as well, in the way that that's perhaps hampered us for some time. So if anything, I would see it being more about collaboration and quite possibly reducing the role of the private sector as the competition side of the NHS changes. So everyone will have a different view, I'm sure, but that's how I would view it at the moment. The second question, again, an anonymous question, is many patients are experiencing great difficulty obtaining an appointment with a GP, even virtually. This inevitably has a negative impact on the hospital as patients are attending A&E for conditions which could and should be treated by a GP. And what can we do to mitigate that situation? So I think on this one, it's a difficult one. GPs locally, I know, are seeing proportionately more patients than they did pre-pandemic. I think the issue that we've got is actually more about the numbers of GPs we've got now post-pandemic rather than them not seeing as many patients. We've got no evidence at the moment that GPs are creating more demand on the hospital system by virtue of the fact that they're not doing as much work. Absolutely not. We've got the contrary of that. But it's quite possible that more people are arriving at an A&E seeking treatment that they may have gone to a GP for, but probably, and looking at our numbers anyway, those patients would have ended up being referred here by that GP anyway. So when I talk about that, if I look at the split of patients that come into our A&E department, there's not really a big increase in minor treatments and minor ailments at all. The increase is in those with sort of fairly major medical conditions. And there's a corresponding decrease in the number of patients who get admitted, actually, we need to bring into the hospital as a result of being referred by a GP. So that suggests that those people have made their way to hospital, probably because of the issues that you describe, you know, the impact of less appointments overall being there because there are fewer GPs around. And those are the patients that probably would have ended up here anyway. So it's a difficult one. Clearly, the answer to this is more GPs. And if there was something we could do to mitigate that, we'd absolutely be doing it. But at the moment, we're just working with our primary care colleagues really closely. Relationships are very good, and we're doing what we can to try and come up with new ways of helping each other, because we've both got real challenges with the current system and the current way things are. There's a third question here, which is on behalf of a member who couldn't attend, from Mitch, and it's what is being done to invest in students wishing to start a career with NHS work. Work placements have been on hold due to the pandemic, which has impacted students studying in health and social care. And what will the Trust offer with regard to apprenticeships in 2022? So a very good question. It's been a real shame and a detriment for obvious reasons that we've not been able to take students on in the same way as we've always done in the past during the pandemic. It's not been safe for them, and it's not been helpful for us. I do know that at the moment that's being reviewed, and we are hoping imminently to be able to say what we're going to do in 2022. We are definitely going to be taking students again, and the question is just about how we do that and how best we make that happen with a sort of mixture of in-person and virtual type support to try and mitigate as much risk as possible. But we're absolutely very keen to get students back in as soon as we possibly can. So I know for a fact that is being reviewed at the moment, and we'll be able to tell you more in the coming weeks. There's no other questions there at the moment, Dennis, so they're the three key ones. I don't know if anyone else has got any comments on those, but unless any others appear in the next sort of 30 seconds, then it may be worth starting your wrap up of the session.
Well, of course, and anyone who's on the call can, beyond the meeting itself, contact us via one of the many routes that they have to ask questions. and we'd be pleased to be able to respond. Colleagues, I do want to, there is one further item of business that I need to put to you formally and to the members, and that's regarding the minutes from our meeting last year, this time in 2020. Normally, if we were face-to-face or in a public setting, I'd be able to ask you as a group, to those of you that were at that meeting, if you would approve them on behalf of the members. Clearly not able to do that virtually. So again, if you have, unless you're unhappy with those minutes, which are available on the Trust website, I shall leave 48 hours before confirming, unless I hear to the contrary, that they are indeed in your approval. And I think that takes us almost precisely to the time that we've got scheduled for the annual members meeting. In closing, my remarks are, look, this, as colleagues have outlined, has been an unprecedented year. Although going forward, I suspect we may be able to attach that label annually to almost every year from now on. But it still has been a year of significant progress for Mid Cheshire Hospitals Trust, and a very successful trust that we've become, but with ambition and aspiration, as good as we think we are, to be better still going forward. We are brilliantly supported by our members and by the communities that we serve. And those of us that are custodians who presented to you today, we deeply thank you for that, and are appreciative of the support that we get in all sorts of ways. During the pandemic, we were flooded with organisations and individuals who wanted to do things for the Trust and do things for the staff. We run very, very successful charitable trust appeals for various things, including some that we have going at the moment. This is your trust. We're pleased that you invest in it, and we're pleased that you place your trust in us to be there when you need us. So thank you very much, everyone, for joining us on this annual members meeting call. Stay safe. You'll forgive me if I express a wish that I hope we do not see you soon at any of our locations, but we do look forward to hearing from you during the year and seeing you this time next year to report on what I'm sure will be another challenging, though I also hope, successful year. Thank you very much for joining us today.